So we are going to talk about the sacroiliac joint. As you've already heard this morning, we talked about reimbursement, some of the challenges and issues. There are about 30 different sacroiliac joint fusion companies on the market with different types of approaches. We have a few of them showcased here. Definitely jump into this area. The sacroiliac joint is a very underdiagnosed area of the human body. And really, if you're practicing in pain management or in spine, you really need to embrace the sacroiliac joint. I hear from a number of spine surgeries, including my own colleagues, who are like, I don't care about the sacroiliac joint. The truth is you have to, because if you're doing any lumbar fusions, those forces are going to distribute to the sacroiliac joint. And there's a lot of debate about how to really address this particular pain generator, whether that's through injections, radiofrequency ablation, fusion. What kind of fusion? Do we need a full fusion? Do we need a partial fusion? Do we want stabilization? Do we want allograft? Do we want metal? Do we want this approach, that approach? So many things to consider. Dr. Beall, take it away. Show us one of these lateral SI joint fusion procedures.
Thanks a lot, Ramo. Okay, we're going to talk SI joint fusion here now. I have my son Grant to help me, to assist. And SI joint fusion is done for people primarily with pelvic instability and after 5-1 fusion, whether it be just 5-1 or long segment fusion. And this is important to know, is essential. You know, this has become very recognizable. SI joint pain is present in anywhere from 15 to 22% of the people that come through your door, especially 5-1 fusion patients come in. They're sitting kicked up on one side, painful side up. They have trouble sitting, they have trouble sleeping, they have trouble rolling over in bed. 3 out of 6 physical examination tests positive for SI joint pain. Injection test positive at 75% more pain relief. This is your SI joint fusion patients. And I have to say, after doing this for quite some time, these are some of my most satisfied patients that I have. It's not like, oh, I feel a little bit better, like, oh my God, thank you very much. I feel so much better. And on the average, the pain relief, the pain and functional improvement is between 40 and 50 points on the VAS and between 20 and 30 points on the ODI. I mean, just huge amounts of improvement. That being said, let's go on to demonstrate. We're going to demonstrate a lateral approach, a 27279. And the lateral approach for SI fusion is essential. I've already marked this out. You can see my mark. This is marking on either side of the needle here. And I'm going to shoot a fluoro image. And you can see that on the fluoro image, this is along the axis of the sacrum that has a dorsal tilt. Because whenever we go superior, according to my marks here, superior, according to the sacrum, is here. It's not here, according to the vertebrae. It's here. Inferior is here. Along the sacrum, inferior to the sacrum is here. Superior is here. This is dorsal, and this is ventral. So this is not superior this way and inferior this way, according to L1. So L1 is different than an S1. This is our starting point. I've already marked this here, so we'll get started. This corresponds on fluoro to right in the mid-body of S1. This is where we're going to start. We see the sacral promontory. We also see the sacral ala, and then we see the vestigial disc between S1 and S2. So I'm going to make an incision right here. It's no more than about 15 millimeters. This is about all you'll need. The incisions are shockingly small for lateral-based SI fusion, and this is coded as a 27279. And so I'm going to put this in and just line this up, and this will take just very small movements. Will have a big difference. And so you keep in mind where you're going. We're going to go a little bit dorsal, a little bit inferior, and we're going to line up and get kind of the right alignment. And that's pretty decent right there, right in the middle of S1. I'm going to move it just a tad bit more inferiorly, right there. So hammer. And this is rigid access. This is what I consider absolutely essential to be able to drive this Steinman, to place the Steinman pin through the rigid access. So I'm going to angle this a little bit dorsally, a little bit inferiorly, and I'm spot on right there. And this is a perfect position for me. And I can feel it starting to get from tap, tap to talk, talk. So this thing is changing tone. So I'm about ready to cross the SI joint. And with this, even if I don't come back to AP, which I'm going to come back to an outlet view. But even if I don't come back to AP, that right there, not what you see on your screen, but what you saw previously, I can drive it from one ilium to the other because that's the S1 bony corridor. And I'm going to come back to cross the SI joint. I'm going to come back to what's called a pelvic outlet view. And this is the pelvis with the sacrum viewed en face. Just push toward me a little bit. Yeah, open it up. Perfect. And we can see it driving across. And I'm going to just drive it across the SI joint. And we can see it coming across very nicely. Right down the S1 bony corridor. And then across the joint, I'm going to take the Steinman pin. I'm going to put the Steinman pin across. And I'm going to put it into the position where I want to. Typically, this is going to be at the 11 o'clock position according to the S1 neural foramen. About right there. And once I have it in position, I'm going to windshield wiper the rigid access 8-gauge non-tapered Jamshidi out. And I'm going to put dilator 1 in. And dilator 1 has soft tissue threads. This is threaded. It's designed to be placed in, rotating, righty-tighty, and this is purposeful. These are soft tissue threads. This comes all the way up to the ilium on the distal tip, and it's sized. And I'm going to take the size from the Steinman pin, and it may be 45, 50, something like this on the average. And I'm going to size it using this. So I'm going to place it through the soft tissue threads, place it through the tissue, and this is placed, this is about even bigger than what I thought. It's about a 50. Let's do 11.5 by 50. I'll take the second dilator, dilator 2. Same thing with soft tissue threads. This will go in, and I'll take the extender, and then the working channel after that. This is a reverse thread. I'm going to put this on, and this thread's in reverse. The reason why it's a reverse thread is you can use power drill or hand drill with this. We don't want the drill to decouple the Steinman pin, so it's reverse thread. And this that goes on, this is a working channel. This is very snugly fit. This is important. It has small teeth. You can put it into the ilium, and whenever you put this in, you put it in, you windshield wiper this in. And it's important to get all the way to the ilium, not to allow soft tissue creep. And soft tissue creep is where people get in trouble, and it's also where it allows unnecessary things to get into the distance between your working channel and the ilium. And once this is in, I'm going to take these other internal dilators out, holding it snug against the ilium. And then I'll take, thank you. So I'm going to take this, go ahead and hold it steady. Hold that for me. Great, thank you. And then we will take it all the way to the screw features here, if we could come in on the screw. This is self-tapping. It's sharp on the front. The thread pitch is differential. It's wider from the front than it is on the back. That means this is a lagging screw. It's rough. It's made out of 3D printed titanium, vanadium, and aluminum, Ti6Al4V. This is medical grade titanium alloy. It's got oval windows, and it self-augers. It draws the ilium graft in, so you do not have to add additional bone graft. All the way to the right, and we're going to take a fluoro shot. We can see the screw going in. And as I put this in, I know from the lateral that we should be in pretty good position, but as we start to advance the screw, I'm going to take a pelvic inlet view. This is a pelvic outlet view. We're just going to switch the II caudal, take a pelvic inlet view. This pelvic outlet view, you can see the S1 and S2 foramina very clearly right there. The pelvic inlet view is going to show us the internal portion of the pelvis, and we can see it, and we can see it angling just a little bit anterior, but we are far away. That top part of the ring, what sits in front of the ring, a little bit lateral to the tip of that needle is the lumbosacral trunk. So it's primarily L5 and S1. You do not want to breach anteriorly, and by the same token, you do not want to breach posteriorly. But I'm going to take this and advance it, and we know from the outlet view that we're doing pretty well. And the bow tie shape that is the sacrum is narrower in the body and wider in the ala. We also know that the body is much denser than the ala. The sacral body is about 90% denser than the ala at S1. I'm getting good resistance, I know, because I'm crossing the SI joint. And the position where the screw is, as you're crossing the SI joint, that's where it will stay. So we're very satisfied with our position on the inlet, and now we're going to go to the pelvic outlet as we drive it across the SI joint. Very nice view, right? And we can see the wire is advancing on us as the wire sometimes binds. The internal part of the screw is rifled, so it tends not to bind and throw the wire forward as much as if it's not rifled, but this is the natural mechanical tendencies of things that we do. And so we're coming up to almost the right position of the screw. And with that, I'm going to ask John to arc 20 degrees toward him, and we're going to take a look down the joint of the SI. As we do that, we get to see two primary things. We see the back part of the ilium, and you see the U-shaped back part of the ilium there laterally, and the screw is almost abutted right toward the posterior portion. So you can see the back part of the screw is really abutted, countersunk just a little bit into the ilium, and we can see our threads are across the joint. We have threaded parts across proximal and distal. I'm going to do lefty-loosey on the knob, take this off, and we're going to come out with the driver. Good screw position. We're going to come out with the wire and the working channel. Very nice. Let's get a pelvic outlet view of that, if we could. And typically we'll place one screw. We'll place an S1 screw there, and we'll place another screw at the foramen right here at this position, and then we'll place an S2 screw right at this position, and we'll put 3 points of fixation. And so people have a debate, it's a little bit controversial, about how many points of fixation we need to provide adequate stability. So good biomechanical paper written by Joe Carr, 55 patients, meta-analysis of this. The conclusion of all of this says definitely 2 and probably 3 points of fixation is necessary to stabilize the SI joint. And so that's what we use. And this system is made by Genesis, and they make lateral, posterolateral, and posterior approaches for SI fusion. This is my go-to. This is something I do. This month I've done 10 already with 2 on the books and more month to go. So we do quite a bit of these, and primarily the patient selection will be those that are fused across the lumbosacral junction, short or long segment, and patients with pelvic instability. 3 out of 6 physical examination test, 75% more pain relief with the injection test. Imaging is not used for inclusion. It's mainly used for exclusion to exclude things like seronegative positive spinal arthropathies, tumor, fractures, those things. With that, I'm going to turn it back over to you, Ramo. Questions, comments?
Awesome job, Doug. I was going to make a comment, but there is a question in the back. Yes. Go ahead and say your question. I can repeat it for Doug.
Oh, sorry.
Oh,
Hi, thank you. Can you comment on the superior gluteal artery injury, especially like the deep branches in relation to the S1 entry point?
Rama, can you repeat that? I can't quite hear it.
Yeah, no problem, Doug. The question was, can you comment on the potential complication of lacerating the superior gluteal artery at S1?
Yeah, so that is, if you look at the MOD database, there's 4 examples of that. So the superior gluteal artery occurs inferior and anterior to where we were. So in all of the variations that you see, if you stay above the foramen of S2 bone corridor and above, there's not a single incidence of lacerating the superior gluteal artery. That's number one. So anatomic position, you have to be in the right spot. I've done hundreds of these. I'm sure I'm clocking over 1,000 SI fusions by now. I've never seen that. I've never done that, but I've certainly heard about that. And the other component, in addition to being in the right position, is to use the right tool set. The reason I emphasized the soft tissue threads, how the tolerances were tight on the instrument, how you put the working channel directly up to the ilium and you keep it there not to allow soft tissue creep, is that if you look at the complications from the superior gluteal artery laceration, they're all too low, and they're all using a device that has a non-circular working channel that, when placed against the ilium, does allow soft tissue creep. So if the ilium's here and your working channel comes here, you have a lot of room up top for soft tissue creep. And up top means here on the cadaver, down low. So that superior gluteal artery that's located inferior and anterior, the dorsal branch of it can creep in. And so I had a discussion with one of the guys who's done innumerable lateral approaches, and we were talking about how, while that's a consideration, the importance of it is way overemphasized as to what it should be in terms of risk, provided that you stay in the right position and use the right tool set.
Doug, to add on to that question, can you guys get a lateral shot of the sacrum, and would you be able to, Doug, either draw it or point out the areas to avoid for neural injury and for vascular injury, just so everyone understands how to approach this safely?
Yes, indeed, and it is important to know, because with transitional lumbosacral anatomy, you get variations in where the location of the superior gluteal artery is. So with this, we have nice screw placement right there. And so the screw placement is right in the middle of S1. Right there, just dorsal, I'm pointing out, I'm at the anterior part of the greater sciatic foramen. If we could have the fluoro shot up, the greater sciatic foramen is right here. And so this is where the superior gluteal artery comes out. So it's located forward, and it's also located inferior. So as long as you stay above the point of my forceps right there, I'm at the vestigial disc of S2, S3. And as long as you stay, so this right there is S3. This is the vestigial disc of S2, S3. As long as you stay right there and above, as long as you don't venture to right about here, which is the body of S3, this is where the dorsal branch will sometimes drift in patients that have transitional lumbosacral anatomy. And that superior gluteal artery will be coming from this spot in the greater sciatic foramen right there. So this territory from right here and below is no man's land. So as long as you stay out of that, it doesn't matter if the person has transitional anatomy or not, you will be okay. So they say if 15% of everybody has transitional lumbosacral anatomy, the patients that you'll be doing SI joint fusion will be much higher than that, double or more, because patients with transitional anatomy often have smaller joints, the true joint, meaning the central part that's hyaline, and the fibrous part that's around the periphery of it. They will have smaller joint surface areas. The joint surface area in a normal individual is about 17.5 centimeters, varying, of course, on size. But people with transitional anatomy will have smaller joints, so will tend to have more predisposition toward SI joint pain.
Yes, Ryan, I have a question.
So I think it's a great demonstration. Questions I had, what does the recovery of this look like for the patient compared to like a posterior SI fusion approach, like, the pain tech for corner lock or silo? And then beyond that, how long is the surgical time for this compared to those other procedures?
Okay, so very good question. Surgical time for this is about 45 minutes, soup to nuts, so you can do very comfortably, very easily in 45, and that is about the right time. So this is for OR time, this is an hour block time. For the post-op recovery, it's a little bit more painful than a posterior SI fusion. So this is about 4 or 5 days of soreness up to about a week. The recovery time, I don't put any restrictions except for I limit bending, lifting, and twisting for 10 days. I say no hard physical activity for 6 weeks. So it's really a function of just limiting activity just to kind of protect what we've done, not to re-injure anything, and to protect the other side. Most commonly, you'll have SI fusion in patients that have SI pain on both sides, and we go for the worst side first. But the pelvis, the SI joints, it's like a ring. So you have one joint that hurts on one side, you fuse that, oftentimes you'll stabilize the ring and you won't need to go on the other side. So the majority of time, we don't need to go on both sides. The exceptions will include patients with prominent pelvic instability, and even one side is very difficult to stabilize these patients. Commonly we'll go on two sides, and these will be the patients that will also be more predisposed to a hybrid approach, fusion down the joint and across the joint.
One more question, yes.
Thanks for the very nice demonstration. I wanted to ask about the screws that we will place at the level of the sacral foramen. So what precautions should we put in mind just to protect the roots and the foramen?
Yeah, just mainly don't go into the foramen. That's the only thing. It's exactly the same orientation as the screw that we just saw. It's the same antero-posterior angulation. The only difference is we work in 3 dimensions. And so if we take the screw that we just put in, if we could put that image back up, the screw that we just put in, even if we were to put that angled directly toward the S1 foramen, which you see just inferior and medial to the tip of the screw, even if we were to put that at the foramen, that's a 45 mil, or was that 45 or 50? 50. This is a 50 millimeter screw. Even if we put the 50 millimeter screw to that depth, you're still not going to be outside the frame, and you can extrapolate that line down. So the only difference is when you put the screw in, you don't want the K-wire, the Steinman pin, to advance into the foramen. And the foramen is also covered with a cortical rind around the foramen. So the Steinman pin will commonly migrate up into the foramen, but very, very uncommonly will transgress across it. In cadaver labs, I've done that purposely, but it takes a little bit of effort, and it takes almost a purposeful negligence, but not looking at what you're doing to drive that into the foramen. So that's the only difference, is just the depth. And watch out and make sure the Steinman pin doesn't bind and go into the foramen as well.
Great points. Dr. Schonard.
Doug, are there circumstances where you augment either autograft or protein augmentation, or does the titanium seem to suffice to get your fusion?
The titanium on these, the 3D printed titanium, I've not had a problem at all with loosening. Some of the other SI fusion devices, you can have difficulty with fusing. Some of just the previous services that weren't 3D printed, they fused most of the time. The paper by Brad Duhan reports about a 15% non-arthrodesis rate. Is that important? I don't know, because these seem to work regardless of whether they fuse, and some of the types of fusion go into the posterior extra-articular recess and are designed to do that and just provide stabilization. But for these, in my experience, and I'm going to knock on wood, but I've not seen one of these loosen up yet. And I have had other methods of SI fusion that have loosened up, that have not fused, have not created arthrodesis. I'm sure at some point in time these will too, but Neil, I'm not using any additional graft. I'm not using anything to augment this, with the single exception is, and this is a different problem, if somebody has sacral insufficiency fractures, that the fracture is hypertrophic, oligotrophic non-union, there's a 5 to 7 millimeter gap or more, then I'll put these across the fracture and augment with cement. But that's not an SI fusion dysfunction. It's not SI dysfunction leading to fusion. This is a sacral insufficiency fracture, of course.
Great point. Any other questions? Awesome job, Doug, as always.
Thank you.
And as you transition over to intradiscal cellular therapy, are there any questions overall from the audience? Anyone?
Hey, Rama, I had a question for you.
Please,
you
Ryan.
do a lot of posterior SI fusion. What are your thoughts just on using this product or this approach versus your experience with
Yeah,
posterior
it's a
SI
great
fusion?
question. So I don't think that posterior SI fusion with allograft solves every single patient's issue that has sacroiliac joint dysfunction. And similarly, I don't think the lateral approach addresses everybody. And we're talking about our patients as if they all have the same sacroiliac joint dysfunction. And as you guys well know, they're not all the same, right? So it can be from degenerative arthritis. It can be from a reactive or inflammatory arthritis. It can be from a ligamentotaxis issue like Ehlers-Danlos or whatever else, in which there's increased instability of that joint. So we don't really know who is best for what, to be really frank. As Doug was alluding to, we think that the techniques or approaches that provide greater stability are better in someone who has instability of the sacroiliac joint. So maybe they're an Ehlers-Danlos patient. But the question there long-term is, in that Ehlers-Danlos patient is, all right, we stabilize that SI joint. What's going to happen to their hip or to their L5-S1, adjacent level disease? Because now the ligaments of their entire body are loose. So again, we have a lot to figure out. I think our diagnostic criteria are going to improve in the next 10 years to figure out what kind of patients we have. The very fact we don't have radiological criteria for this particular issue is concerning to me. I think we need them. We need to really dig deeper and to identify who is unstable and stable. And I'll say this is sort of the corollary of lumbar spinal stenosis. Lumbar spinal stenosis is not a diagnosis by itself. You can have it from, an old disc bulge, facet hypertrophy, ligamentum flavum hypertrophy. There are multiple reasons for stenosis, and different therapies are right for these different reasons. So to put that all together, I think right now there's a role for all three approaches as we see it right now. We're still figuring out what is right. And one of the papers I was involved with, and maybe Ryan, you were too, at least I know Dr. Deere was our SI joint salvage paper. And there's salvage on both sides. We have salvaged lateral approaches with allograft from a posterior approach, and vice versa. Lateral approaches has salvaged. I've salvaged lateral approach for my posterior allograft patients. So I think having these options, both of them are good. It brings up the discussion: is a hybrid method maybe the best? And people in the audience might be thinking, these guys are crazy. They're just going to do whatever it takes. Well, the logic behind that is you create distraction with the allograft, and then you create compression around that allograft with your lateral approach, whether it's posterolateral or lateral. And therefore, with the allograft, create that stabilization plus the metal. So there is some logic behind that, but we just have to gather the evidence and the data to really prove what is right for which situation.
Yeah, I mean, clearly, it's some people say, well, just try the posterior approach. Maybe it's not quite as locked down. Maybe it requires a revision. Okay. Maybe it requires a revision. But a posterior approach with a single allograft is something you could do almost under local anesthetic in a very short amount of time. So you're not sacrificing it. If you view it as the patient's your own mother, presuming that you like your mother and she's a nice woman, you can keep in mind to do whatever you would do logically and appropriately. We absolutely need all three approaches. So for somebody who's treated patients with big time, chronic, long-term pelvic instability, these things are tough. They're snakes in the grass to treat. And a lot of times we'll go ahead and just do, I'm sure Dr. Shauna agrees with you, just do a hybrid approach, straight off the top. Maximally, you put, I've seen them done with cervical cages and then lateral screws, cervical cages inside the joint for retraction arthrodesis. But these are, you use them for different reasons. You can use the lateral for a salvage method. You can use the posterior approach for your initial method. What we do is we're kind of a lateral approach or posterolateral approach, straight off the top, small incision, a little bit longer recovery, a little bit slightly more painful than a posterior approach. We want to do it once. So there's no right way to do this. I think there's reasons to and not. And what's essential is that we have all three approaches. And there are actually 7 approaches to the SI joint, but there are 3 most commonly done. I'm not going to do the anterior approach through the front of the pelvis. Never. Dr. Shauna might do that, but not me. Yeah, it's got to stay away from that. But it's as Ronald pointed out, we fought long and hard to kind of preserve and salvage a lot of these approaches and make sure the reimbursement makes it worth doing. And so people don't just ignore people with SI joint dysfunction, which is incredibly debilitating.
Doc, how does this approach compare to SI bone and their traditional approach?
So it's pretty similar. The SI bone is the triangular titanium bar that goes across. It has it's changed over time. It's now has perforations in it, and the approach to SI bone is similar to that of Rialto, made by Medtronic. SI bone has a new fusion. It's called the torque screw with a Q. An almost identical approach to this. And the lateral approach was, as you know, originally touted by SI Bone that came out. It came out in 2009 as a public company. And this is the Sci-Fi, Insight, IMEA, Lois data all belongs to them. So great credence and good show you for developing the space and putting the papers behind it. But there are now 55 companies that have SI joint fusion devices, so there's no shortage, in case you're wondering.
Well, forgive me for not mentioning the transintestinal SI fusion approach. So, Doug, with that, let's have you come on up and talk about intradiscal therapies. Thanks.